We discussed about glomus tumors, its etiology, then epidemiology, classification, clinical features and management options. So, we know that the definitive treatment is surgery. So, what are the surgical approaches for removal of glomus tumors? For any surgery, how can we decide which approach is needed? That is by asking three questions. One is, where are we going? That is the target. We have to remove this target. So, where are we going? That is the target. How do we get there? That is the surgical corridor. We should know the surgical corridor by which way we have to and the where to start with. That is the door of entry. So, for any operation, we should know decide the door of entry, then the surgical corridor and target. So, we have to remove open the door, that is our incision and the entry. Then there will be a pathway, that is a surgical corridor, and then we will reach the target, so we have to remove that. So, as in the real life, in the surgical corridor, in the walkway, we can have many obstacles. So, sometimes we have to remove the obstacle, like that in a bone. If it is a bone, we can remove that. Sometimes we have to retract. What all things we can retract? In case of especially glomus tumors, we can retract cerebellum, brain, etc. Some cases we have to displace it. Example, the facial nerve, then the internal carotid artery, etc. And in some cases we have to bypass it, like that of labyrinth. Okay, so all this. So, if you want to reach the target in a systematic and without any complication, this shows the importance of knowing the anatomy. Okay, so study the anatomy, practice it, do cadaver dissection to the maximum or temporal bone dissection, whatever it is. So, this decides which surgical approach is needed. So, we know that there is glomus tympanicum and also there is glomus jugulare. So, this depends upon the size and the extent of the target. So, in case of glomus tympanicum and in case of glomus jugulare, we know that Glasgow and Jackson staging into type 1 to 4. So, depending upon the type, we can decide the surgical approach also. So, for glomus tumors it is different, and for glomus tympanicum and for glomus jugulare the approach is different. The stages were already discussed. So, for glomus tympanicum, you know it is stage type 1 is tumor limited to the promontory. So, if the tumor is limited to the promontory or the mesotympanum and all the margins are visible in otoscopy, and it should be confirmed by imagiology also by doing a high resolution CT scan and MRI scan, and by otoscopy if you can see all the margins, you can go by a transcanal approach. The temporometer flap is elevated. You can avulse the lesion from the promontory and the margins are cauterized, and the hemostasis attained either using a bipolar cautery or using small cotton balls or gel form dipped in 1 in 1000 adrenaline. Okay, so type 1 it is a transcanal anterior tympanotomy. Okay, tympanotomy. And removal of the mass using bipolar cautery and getting the attainment of hemostasis. And also you can give a light ear packing. Okay. And if it is type 2 to type 4, that means type 1 I already discussed. Type 2 is filling the entire medullary cavity. Type 3 is extending into the mastoid. And in type 4 it is extending to the filling the entire medullary cavity, extending to the mastoid. It is through a tympanic membrane perforation. It is extending into the external auditory canal, and also it is going anteriorly to the internal carotid artery. But the floor or the jugular fossa is not involved. In that case, that is 2 to 4, we need a very good visualization of the mass. So it is always better to go with a post-aural approach. Okay, so post-aural approach, then after that a complete mastoidectomy. Then after mastoidectomy, through the facial recess approach, and in some cases we need extensions of the facial recess. So facial recess approach plus its various extensions. So we can remove the entire mass. Even if the hypotympanum is involved, in some cases we have to drill the tympanic ring at the inferior aspect, but external auditory canal as such is not drilled that much. And in a hypotympanic masses, we can drill the inferior part of the tympanic ring. Okay, and after this, after removal, the reconstruction of the hearing, tympanoplasty. Depending upon the type of bone involvement of hearing, tympanoplasty, different types of tympanoplasty can also be done. So here also we can do this either with your cold instrument or laser can also be used. And endoscopic removal is also used nowadays widely. Okay, so this is regarding Glomus tympanicum. So type 1, it's limited to the mesotympanum, and all the margins are visible by otoscopy, confirmed by imagiology. Go with the transcanal tympanotomy, or after elevating the tympanometric flap, avulsion of the lesion with the bipolar cautery and getting a hemostasis. Then 2 to 4, it is going with the post-aural approach, post-aural incision, complete mastoidectomy, facial recess approach and its various extensions, and after that reconstruction of the hearing mechanism. So this is regarding treatment or surgical approaches of Glomus tympanicum.